Kenyatta National Hospital. Today we will be speaking on home-based care, and we'll be hearing perspectives from Mombasa County. We'll have people telling us how the experience was for home-based care, and then we can be able to ask our questions. So for CPD points, these webinars are CPD accredited. And if you haven't received your CPD points, kindly email us at knhcpd@gmail.com and we'll be able to resolve all the problems. My apologies. I seem to have had some challenges with the internet. Our presenters will also be joining right now. So we will start in a short while. Thank you very much for your patience. Good afternoon, everyone. Apologies for the delay. Our presenter is having a bit of some technical issues.
Mombasa County, and we're basically going to talk about patients' perspectives. Those, especially those who we have managed to discharge and manage on home-based care. Unfortunately, I didn't get many patients, but I have one patient who will take us through his experiences. But before I get on there, I just want to project one or two slides that will probably show us our journey with the home-based care. So if I'm allowed to share the screen.
You can share your screen. We've allowed you.
All right, thank you so much. So I want you guys to pay attention and see. Just a minute. Right. So the screen that I want you to see is this one. So remember initially, okay, our numbers for home-based care have not changed that much. We are currently standing at 116. The reason why we have not had a very big increase is because, as you all know, Mombasa County has been recording lower numbers of late. However, I wanted to show you this, that the number of negatives following testing from home-based care currently stands at 78 out of the total 116 patients. So this is an encouraging number. When we had started this exercise about a month ago, it was very low, it was around 40 something. So in just 1 month, another 30 plus patients have turned negative. So we have seen that home-based care has actually reduced the turnaround time of patients seroconverting from positive to negative. So that's the main thing I wanted to show you, that we have a good recovery time or seroconversion time. And we are also doing a research from my center, Coast General Teaching and Referral Hospital, and we hope to publish very good results from that. So that's what I wanted to show you. I'll stop sharing screen now, and I will invite one of our patients, Mr. Kasam Baradia. Mr. Kasam Baradia is a male patient, 46 years of age. He was admitted as a severe patient. He was severely sick. He was at our ICU for quite some time. Luckily, we had high flow nasal cannula devices, so we didn't intubate, but we used high dose steroids on him, and he recovered. We discharged him to the ward, and from the ward, he went home where he eventually seroconverted. So I think I'll allow him to start talking. And if there are any questions, you can probably I can probably take them on his behalf after he's done. So Mr. Kasam here is, and hello, good afternoon.
Good afternoon. We can hear you.
Yes, ma'am. How are you?
Hello. We just need to talk. Tell them about your experiences.
Yeah.
Just need to talk continuously. Tell them about your experiences. Home based. Were there any challenges?
Starting from the hospital.
Yeah. Were there any challenges you faced in home based?
Okay, I was admitted on the 2nd of June, having diagnosed from the Mombasa hospital with the CT scan as severe pneumonia. And then after that, I had to be admitted at Coast General. And when I was admitted, I was told that my oxygen level was going down, the breathing level was going down. So they had to put me in ICU. I was in ICU for 8 days. And after all the treatment I went through, it was a very severe case. They were on their toes day and night, serving. In fact, everybody, those who were in the ICU, were serving. And Alhamdulillah, I started recovering. And then after 1 week, I was in isolation in the ward. There also, I was feeling much better, but still weak. But after taking good care from the doctors and the nurses, I started building myself. But they took my test for the second time. It still showed positive, but since I had no symptoms, as a symptomatic patient, I was released. I went home, still in isolation for another 1 week. I had to take another test. Uh, and a lot of, there was no medicine I was taking, but a lot of steaming, uh, healthy foods, fruits, vitamin C tablets I have been taking. So another third test was taken, but still it showed positive. So still, I still continued with the same steaming, doctor's advice, been calling the doctors, and alhamdulillah, it was a very strict isolation at home. The fourth week, they had to take my test again, and it showed negative at last. So that's all what I have to say, since I passed through all that. After going through all that, there are many people of ours, in fact, the whole country, they still don't believe that COVID is not there. It's still there. They still don't believe it. But after I have passed through all that, I realized that this COVID is there, and we have to take precautions. Early precautions. If you take early precautions, you don't go through all that. You don't go through all this hectic, this ICU, this. If you take early precautions, my family was in isolation also. My wife had symptoms, though she was not tested, but she had taken early precautions like green tea, the steaming, this ginger water, lemon water. This is what helped her. And she was in isolation for 2 weeks, and there were no symptoms after that. and she was safe and sound, together with my family members who were on isolation also in 2 weeks, for 2 weeks, and there were no symptoms on their side only. So early precaution really helps fighting this bacteria. So the people have to know that the disease is there, but it's just that you have to be precautious and uh, and take the necessary precautions available, like washing of hands, sanitizing, everything to maintain cleanliness, to avoid that medicine go through your body. Face mask has to be there. So please, I would advise the people to just take care and not go through all this which I've gone through. Yeah.
Okay, thank you so much. Now back to my talk. So I wanted us to hear what his views were first before we can probably give him particular questions which he can give us an insight of the answers. So, hello, Nancy, can you hear me?
Yes, yes, I can hear you well.
Okay, so now there are some questions I want him, I've written them down for him right now. I want him to probably tell us, one, does he think that home based care helped him? If yes, in what way? Two, regarding the home based care, did he face any challenges while he was at home for the home based care? Three, how was the follow up done when he was on home based care? Uh, like, were there doctors, or was it like myself? Did we communicate over the phone, the public health department, and retesting? How was the retesting done, and at what intervals it was done? I think that those are the three main issues that we want him to tackle. I don't know from your side, Nancy, if there's anything else you would want him to tackle before I hand over the microphone to him.
He can start with those ones, then we can ask the questions that other attendees have. So he can respond to the questions you raised.
All right, fine. So, Mr. Kasam, the first three, please. Uh,
Okay, the first question is, did home-based care help? Of course, from my side, being at home with the family, although isolated, brings a lot of change because as you are in the hospital, you feel depressed. Nobody's around to talk to. It's just the doctors who just come and check you up, and that's it. Then I've been spending a lot of time looking at people, and I was getting bored when I was in the hospital. But when I was at home, the family was there. You are satisfied that the family is safe with you, although they are still isolated. You are far from them. You're just near. Anything that food that is the care which they give you is extraordinary. Although the doctors give you that care also at the hospital, but still you find, if they were your own members of the family, you get very much satisfied. The the time to time that the food which they give you also, you see, it depends. The hospital food is not bad, but there are some families like us, my Asian type, we have got some extraordinary vitamin food which we get, which we don't get at the hospital, and that really, helps us to to build our body, and you are satisfied with, in every way you are satisfied that the family is with you. You are not depressed, being that you are with the family. The second question is, were there any challenges faced? Now, challenges like,
Home health care,
huh?
like if you have enough masks, gloves, disinfectants,
Uh,
that's an incident.
okay, for that, at home, like myself, I was fully equipped. I had masks, I had sanitizers, I had everything was prepared there for home, because it's not for all people that there are no challenges. For my side, I was all right, but there are some people who sometimes cannot afford to have those things, being at home also. But always there is a trial for that, that if you are home based, you have to have those special equipments, the special like masks and sanitizers, so that you can avoid uh, being infected again with the same bacteria. And the third one is, how did you get followed up? Of course, there were doctors like Dr. Arif Parwani that he was calling up. He was getting new updates on how uh, I was doing at home. We had officials from the health officers. They were also calling up. They were asking us how my situation is. Though they had come to see where I was, they had come to see, and for 2 3 times they called, and I had to explain them what we were doing. Yeah, we were safe and sound at home. So these are my views as home based. So I really grateful to the doctors who are really following it up after I was released. There were 2 3 doctors from the Coast General Hospital. One of them was Dr. Arif, the other was Sheikh Shazim, who are really following it up with me. Thank you very much.
All right,
Thank
thank
you
you so
very
much, Mr. Kassim. So Nancy, over to you. I don't know if there are any other questions.
I think there are questions from the attendees, and one is I will direct a question to you, even as we give Mr.
Yeah,
Kasim some time to take a breather.
yeah,
So
sure.
someone is asking, how do you make sure that the patients don't break the rules during this time of quarantine while at home? And the bigger question is, what advice do you give to them even as they are going home? What do you tell them to do? And what should they not do? What do you say?
All right, thank you so much, Nancy. So I will answer the questions step by step. So before we get to answering the questions, there is a group from the Coast General Teaching and Referral Hospital currently at Mombasa County, where we are looking at for answering a research question that sending patients for home-based care versus sending patients for home-based care after some educational session is given to them, like motivational interviews and some formal education regarding the disease, COVID itself, and how to self-isolate and how to go about self-care. Is it having a difference? And there is obviously a tool which is being administered in terms of a questionnaire uh, post the intervention to see if the intervention is having any effect. So we're also waiting to get our results and publish them shortly. But yes, we have seen a remarkable improvement, and that's what we have been doing. So currently what we do, and I remember presenting the same a month ago, is
Hi, Dr. Arif. We can't hear you.
the process.
Hi, Dr. Are you on mute?
Fine. Okay, can you hear me?
Yes, we can hear you now.
All right, sorry for that technical hitch. So, all right, just a minute. So yeah, I was telling you about this. So yeah, as I was explaining regarding home-based care, it's not something that sorry. So it's not something that is a one-man show. Instead, we have a team called the home-based care surveillance team, and I'm looking for the page. Just a minute. Hello,
Hello,
can
we
you
can
hear me
hear you.
now?
Yes, we can hear you.
Okay, fine. So let's go direct to the page where I was explaining about home-based care and how we go about it. So you see, with home-based care, um, you have to continuously follow up our patients, and this is how we do it. So there is a home-based care surveillance team. So every patient who is due for home-based care first undergoes a discussion by the home-based care surveillance team. Then the second step, the public health officer has to verify the residence of the patient to make sure that it meets the requirements. Once you have made sure that it actually meets the requirements according to the guidelines set aside by the MOH, is when now we explain and educate the patient regarding the rules and regulations of home-based care, and the patient actually signs a self-isolation declaration form. Now, in the declaration form, it is clearly stated that upon impromptu checkups, should any of the rules and regulations be found to have been breached, then the patient will actually be admitted for hospital isolation. Um, After that, there is a designated vehicle or an ambulance that the patient uses to go home, and then there is a scheduled follow-up, and that's how we have every patient assigned to a particular public health officer, to a particular doctor, a particular clinical officer, and we from the ground, the clinical officer, the doctor, and the public health officer, we make calls to the patient to find out about how the patient is doing, and we also do impromptu checkups, and we also have scheduled follow-up testing. Now, I know one of the questions that has been asked from the attendees is because of the shortage of the testing kits, why shouldn't we go and follow the CDC guidelines? Yes, by all means, it would be very good to follow the CDC guidelines that after 10 days we don't test. But now you see, currently we cannot afford to do that, because at times you will be on your day 10 and you will be on your final day of viral shedding, and you say, okay, I've done 10 days and now let me go out. You go out and infect another member of the family who will start viral shedding and will continue the process. So for us currently, we are following the safest way, and that is by repeat PCR testing to see if the patients have actually seroconverted or not. We are yet to see guidelines from the Ministry of Health, but should we get guidelines, then I'm sure we'll be able to follow them up.
A question to you, Dr. Arif from Marlin Chesang. How often do you check up on the patients who are on home isolation? So what's that schedule like?
Okay, so the schedule, it depends. There is clinical checkup. So a call is made once every 3 days to the patients by the clinical team. Then there is the public health team that does the follow-up retesting, and that is done once every week. So some patients are assigned on a Monday, some on a Tuesday, some on a Wednesday, but they have been assigned as per the day of discharge, so that once a week a follow-up test is done. However, on the self-isolation declaration form, we have two hotline numbers belonging to the Coastal Hospital command center. Now, those lines are open 24/7, and we usually encourage the family members, the patient, and the relatives or the household, and we clearly explain to them. So if there is any issue with the patient, like a fever or a new symptom, or if any of the household members develops a fever or any symptom, then the household members are also encouraged to call, and we go about their testing as well.
Thank you very much for that, Dr. Arif. And I'm seeing quite a number of questions asking the criteria for home-based care. So like Eunice Wambo is asking, how is home-based care workable in a single room, in a bed sitter? So how do you do it so that the people in this forum also know the criteria or the living arrangement that can work for home-based care?
All right, thank you so much for that question. Now, this is a very pertinent question because, as we know, not everyone is capable of living in a self-contained room. Not everyone will be lucky enough or will be well off to have their own flat or their own room to isolate. So as you can see, there is a checklist from Ministry of Health on the screen, and there are 5 prongs, the 5-prong approach. There is the infrastructure. Do you have the particular infrastructure available? There is accessibility. How safe and accessible is your place? There is accommodation. Do you have a separate, well ventilated, self-isolated room, or are you sharing washrooms and bathrooms? There are resources as well, and then there is primary care and support. So it's not only the single room, but I will tackle the question asked about the single room now. If you do not have your dedicated self-contained room, then there is no way that it would be possible. However, if the patient can undergo some form of education before they are taken to their places for self-isolation, and they have their own room, then the patient can stay in their room. They can share a washroom or a bathroom, provided that immediately after every use, the patient should disinfect the washroom and or the bathroom fully. Now, disinfection is usually done by use of 0.5% chlorine water, and all this is part of the education that is imparted to the patient. So that's the educational part of it. So once you impart the education to the patient, and the patient can follow that strictly, then the patient can be allowed to go and self-isolate. So that's the education part of it. Now the second question is, and that's why I put up the question to Mr. Kasim, did he face any challenges? And he said no, he did not face any challenges because he had enough supplies, he had enough disinfectants in place. So if you do not have access to the disinfectants, then the patient can be allowed to go and self-isolate. So that's the educational part of it. Now the second question is, and that's why I put up the question to Mr. Kasim, did he face any challenges? And he said no, he did not face any challenges because he had enough supplies, he had enough disinfectants in place. So if you do not have access to the If you don't know how to make them, or you cannot get fresh water, running water to make your chlorine 0.5% chlorine solution, or you cannot buy the chlorine powder itself, then there is no way I would allow you to self isolate, because that particular communal use of a washroom or a bathroom would actually be the point of spread to the other household members. So those are the patients. We actually educate them and tell them that, look, you cannot have these things available, and we eventually have to isolate them here at the hospital. After them seroconverting is when we discharge them home.
Thank you very much from that. There's a question here from Dr. Simon Kandi. And he's wondering, is there a role for relatives at home? Like, can the patient get assistance from relatives? And then the follow-up question now is from Tony Kiraive. So if there is a role, what PPE would you recommend for those attending to them?
Okay, again, very good question. I must say, yes, there is a very big role of the relatives to play. Now, as you heard from Mr. Kasim, there is that psychosocial support that the relatives do provide. Now, apparently, when you're in self isolation and so is your family, you don't share the room. So, there is no way you would come into close contact. However, we have some patients who have comorbidities uh, and who are very elderly, and unfortunately, these patients have to have a caretaker alongside them. Now, according to the guidelines, the caretaker has to take precautions, and we have to provide them with the PPEs. So unfortunately, it's beyond us, but for level 2 PPE is what they need, and that is an KN95 face mask. If they cannot get a KN95 face mask, a surgical face mask is okay. There is a face shield, or at least eye protection, and they need a disposable gown plus gloves. Now, if you go and see many of our families or many of our patients who have caretakers will not be able to acquire all these. So we usually give them a choice. If they can afford to acquire all that, and they can abide by the rules and regulations, we continue care at home. But if that is not possible, here, especially at Coast General Teaching and Referral Hospital, we prefer keeping such patients within the hospital. Main issue being the financial part of it, because it becomes very expensive at the end of the day. Um, at the Coast General Teaching and Referral Hospital, for example, I would want to explain further. We have around 4 patients who are on hemodialysis. They undergo dialysis twice a week. These patients, however, are very stable, but we could not just ask them to self isolate at home because of the logistics involved. Because you will need a dedicated transport system to bring them from home to the hospital during dialysis. They get dialyzed, and after the dialysis session, they go back with the same transport system. And then that becomes quite hectic, because if you ask probably people from the public health department to do that, that would become very cumbersome, because we have to dedicate an ambulance to that particular patient. It goes, picks the patient, brings the patient to the hospital. Then the nurse or the public health officer who is attached to that patient will have to wait for 4 hours in PPE, and then after the dialysis, take the same patient in the same PPE back to the same ambulance. So for 4 or 5 hours, you will have a member of staff, you will have the ambulance itself just on standby, just for one particular patient. Unfortunately, we are running short on our human resource, and also on our uh, other facilities like the ambulance facility. And there was quite a shortage on some PPEs once upon a time as well. So for such patients, we try and maintain them in hospital.
Thank you very much for that. There are a few questions to the patient, Mr. Kasim. There's
Yes.
a question here from Moses Mwenda. Did you face any stigma at the time, and if you did, how did he handle the stigma from his neighbors or friends or even the community?
All right. Let me just ask him to answer that. Just a minute. There is this question. Did you face any stigma from family, friends, community, neighbors? And if yes, how did you handle it?
Any problems?
And the stigma, like people are running away from you.
Uh, being at home, the family was right with me. Although isolated, as me myself being with them, I had no issues with my family. But there were some friends, and we had already informed of my family, my friends, my community members. Since I was in isolation, together with my family also, we had to take precautions. We told them, we requested them not to come home. Although there were some who wanted to come, they were not. They were being not. They were not being affected by this, whether I had COVID or not. But many of the members of the family, like my cousins, the community members, they were being afraid to come home. So, it happens that they were afraid of that contracting that disease. So they were also taking precautions on their side. Uh, but myself, we had requested the friends, family not to drop by my place for at least 3 weeks, and then afterwards, then there is, I know that since there will be no symptoms with my family members and myself also, but till today we are still taking that precautions. We are avoiding gatherings. We are avoiding many family members to come at one time. Yeah. This is what we were facing.
Thank you very much. Maybe one last question that's been asked by Yunus Mwiti. So, how was it being at home in isolation and your loved ones being in isolation?
Okay, so Mr. Kasim, there's another question. They are asking you, how was it that you are at home, but you are in isolation and your family was also isolated from you? How did you, how was the experience like? You are at home, your family is at home, but you're not allowed to meet. You are in isolation and they are isolated from you. Could you please explain how that experience was?
Me being in isolation, together with my family, I was not able to interact with them. Uh, we had to take precautions on that. We had to take precautions so that me being a COVID patient, and to my understanding also, I love my family, so I was avoiding also them to to contract this disease, because I've gone through a lot when I was in the hospital, and I know I didn't wanted my family to go through the same thing. But also, of course, uh, that interaction of hugging, shaking of hands, you see, with your partner, with your kids. They really wanted me to hug them as the father, but it was not possible. I had to stay away from them, but at least we were keeping that distance of 1 meter, but we were satisfied that we could see each other, talk with each other, you know. So at least being at home, it was better rather than being in the hospital, not seeing your family members. Yeah.
Thank you very much, Mr. Kasim. Maybe right now I would like to open the floor to one of our panelists, Dr. Mary Beth Maritim, to actually give her comments, maybe, and Professor Ruth Nduat, even as we go on with the other questions.
So, good afternoon. Thank you very much to the team from the coast. And thank you very much, Mr. Kasim, for coming to share with us your experience, your family's experience. And we thank God that you have recovered. And we pray that you will have good health going forward. My observation to the team here and to the many participants is that what Coast General is demonstrating is what home-based care is about. On Friday, we heard how the city of Nairobi is doing it. And I think clearly they have a problem, and many counties have a problem. Home-based care is not ditching your patient. Home-based care is not making a diagnosis and telling somebody, go home, you're on your own, and failing to even show up to be available to support them. Home-based care requires planning. You need to have health workers available to follow up and support families so that we are successful. So my appeal is that, and home-based care is also not setting up family members so that they go and infect their fellow family members, their fellow community members, which is actually what Nairobi City is doing right now. Home-based care is about a partnership for care, a partnership for protecting our communities. And I want to just say thank you very much to the team from the coast for demonstrating that it is possible if it is done carefully and with a compassionate approach. Thank you.
Thank you very much, Professor Nduati, and I echo your sentiments. I think the coasts, Mombasa is a county that we should all emanate in terms of the care that they give to their COVID patients. Dr. Mary Beth Maritim, comments?
Good afternoon, everybody. Sorry, I was on a long phone call, so I missed a lot of the deliberations, but I was there at the beginning. I think what we can learn from today's experience sharing session with Coast General is that they have led the way. Coast as a county, Mombasa County specifically, have led the way in terms of really teaching us what to do with COVID patients. Initially, they had a lot of cases. They've gone up through the worst part, and now their cases have settled. And even as they implement the home-based isolation and care guidelines, we're actually learning from them. And one of the things that Prof. Nduati has also echoed, it's really, there's duty of care. When we make a diagnosis of our patients, certain things, whether they have symptoms, the severity of their symptoms, suitability of judgment, this patient facility or in a hospital setting. And when all these are costing for home-based care has already been done. And we should not use home-based care as a cheaper alternative where we want to forfeit our duty of care. Patients have to be nursed where they can for the best outcome, whether they can afford or they cannot afford. So we should not look at home-based isolation as a cheaper alternative. where we abandon our duty of care, and therefore patients who go on home-based care should fulfill the minimum criteria that has been put in the guidelines. And I know we are having a lot of teething problems, but we should not abandon our duty of care and make some patients stay at home, and then they come to our facilities when they are collapsing because we have not provided compassionate care. We have not followed them up even during the entire period when they are going through the natural history of the disease. And we clearly know that the disease has, we have the viral phase, and then we have phase. Dangerous because patients can change condition. So even as we implement home-based care, we need to watch out for those people who can decompensate, provide a safety net, educate our patients what to look for when they're deteriorating and how they can be evacuated or their care can be escalated by linking them up with facilities that can provide appropriate care. Because even as we send patients for home-based care, we are cognizant of the fact that they can deteriorate, and we need to know how to quickly move them to facilities and provide care so that they don't lose their lives in the process of trying to reach facilities where care is optimal. So those are just my sentiments. And even as counties implement home-based care, there's duty of care that has to be inside there. And I know training is planned in the near future for optimal implementation of home-based care. Thank you.
Thank you very much, Dr. Mary Beth Maritim, for your insights. And maybe before we ask, I shift the questions to Dr. Arvani. Maybe you can comment about the issues of testing and the change of guidelines, where right now, because of issues of supply of testing, there's that issue of after you've been isolated for 10 days, you can resume work or you deemed to be fit. Is that something we should adopt, or what are your thoughts?
So in the home-based isolation and care guidelines, we clearly put in there that if testing is available, then it can be offered. But even the case management guidelines, we're in the process of reviewing them. And one of the things from evidence that has come from elsewhere, from Singapore, has been taken up even by the European CDC, American CDC, as well as even WHO. It has been found that patients are, the infectious period is about a 10-day period when they are highly infectious, and therefore de-isolation can be offered after a 10-day from the time of onset of symptoms or from the time of positive test. So this will go into the new guidelines. But what we are recommending, even for people who finish the 10-day isolation, just as a way of protecting the people surrounding them, and even for protecting other family members, that they can still continue to adhere to precautions that can limit their production of droplets. So by wearing masks, particularly even within their household, as well as even ensuring that they do perform hand hygiene and maintain a physical distance for a further period of about 14 days from the time they finish the 10-day isolation. So I know the coast have presented, and they say they are actually doing tests for patients to be a criteria for like integrating them back into the community and confirming that they are negative before to release them from home-based care. So that comes with a lot of challenges because we don't have adequate resources. So for the new guidelines, we are recommending a 10-day period. But if somebody had been symptomatic, then you have to finish a 10-day period and then 3 days when you're symptom-free. And symptom-free means like if you had fever, your fever has settled, you're not taking any antipyretic to control the fever, and you have been symptom-free for a period of 3 days to say that actually you can stop the isolation procedures. But beyond that, we are still encouraging that they adhere to the public health measures of masking, hand hygiene, and physical distancing. On a caveat to that is that for healthcare workers, we would like them to have 2 negative tests before they can reintegrate. And this is because when you look at a healthcare worker, really, the concern is that even as we await more evidence and we have limited resources, we don't have like too many healthcare workers, and the implication of a healthcare worker who's still maybe shedding virus as a public health in terms of risks to patients that they care for, then in terms of like prioritizing the testing, then it's healthcare workers that need to be prioritized in terms of the negative test before really going back to work. But for the general population, we can only test at the beginning. We don't need to test them to discontinue the isolation procedures. I hope I've clarified that.
Thank you very much, Dr. Mary Beth Maritim. Maybe you can go back to Dr. Arvani on the questions that a lot of the attendees are having. So this is from MTRH, and right now, I think all counties are looking into ways to implement their home-based care, and they're asking, so for the patients who have comorbidities, how do you evaluate who fits for home-based care and who does not fit for home-based care? And in terms of nutritional services and counseling, so how do you assist them to be able to get the optimal counseling and nutrition?
Okay, thank you so much for that question. Yes, we have had some patients. For example, I will give you a scenario from Coast General Teaching and Referral Hospital. We have had an incident where we had a patient who was asymptomatic, but she was diabetic and she was on insulin. Now, unfortunately, this lady was elderly and she was not comfortable with injecting herself. So she had a daughter who used to do the injections. So what we did, we actually talked to the patient and the relatives because they had already arranged for a self-contained room for the patient. So we actually arranged that the patient stays with us for the first 10 to 14 days, by which time we were expecting that the infectivity will have gone away. So from the time she was admitted to hospital, she was asymptomatic, but we admitted her and we continued her care until day 14 when we discharged her home. And we discharged her home because we were comfortable that 14 days have passed without any symptom and she is not infective anymore. So now they can continue care at home and the caregiver can continue giving the insulin. Yes, it is very hard, unfortunately, because we have had some times when some people will ask you questions. Some patients will ask you, why am I being left and others are being discharged? So it's very difficult, but a lot of counseling needs to go into this practice. Another thing is, I think this is a very important point and I would want to stress on it, that anyone can be infected by COVID-19. We need to take this as a disease and not a criminal offense. I have seen some healthcare workers run away when they hear that someone has COVID, or the approach to the patient takes a totally different approach. Now that is something that we have totally shunned at Coast General Teaching and Referral Hospital. We have had very good integration of all our doctors, all our clinicians, all our nurses who are working at the COVID isolation unit, and we have maintained that closeness to our patients, one, and two, we have tried as much as we can to be the link between the patient and the relatives, because many a times it's an isolation unit, the patient cannot see the relative, so it becomes, like there is a cutoff from the social world for the patient, which is actually not right. And we tried being that, and that's why we have seen a good turnaround time in terms of patients seroconverting to negative. And as you can see, it's also very evident from our home-based care numbers that people are turning negative faster than they were before when they were in the hospital. So yeah, that's one thing that I would like to really emphasize on, that be the link between the patient and the society.
Oh, I think that's really, really amazing, and that's something that all the counties should actually adopt. in terms of, and I like how you've put it, having COVID-19 is not a criminal offense. It's a disease that can be managed, and that as healthcare workers, we should be the link for the patient. I think I'll ask a question here from Dr. Maria Mwangi from Meru Level 5. I don't know whether you have it, Daktari, with you, but they're asking how the format for the self-declaration form is. Maybe you can give a highlight, and if you have it, you can share it.
Yes, I do have the self-declaration form. I will. It's much just like the. It's much just like the self-declaration form which we had upon patient's entry into the country. I'm just looking for it. Just a minute. So I'll share screen in a minute. All right, so I would want to share my screen. Um, just a minute, and here. So as you can see on the screen, it's more or less like the Ministry of Health quarantine declaration form, which was in use during the initial stages when patients or when people were traveling from outside coming back to the country, and they had to declare that they will actually quarantine themselves. There are some slight changes. For example, we have said I dash of ID number dash having been discharged from CGTRH, which is a COVID-19 isolation center, after having stayed asymptomatic for the past certain number of days and having been advised by the doctors as per the guidelines, do commit to undertake self-isolation and scheduled follow-up. So there are those do's and don'ts which are there, and as you can see, let me just, during the self-isolation period, I shall strictly observe the following. So they have to actually do all this. And point number 9 says I shall allow to be tested once a week by a designated public health officer until that time when I turn negative. Point number 8 shows the 2 hotline numbers that they are supposed to actually notify, and they actually sign that they have read and understood the statement of commitment, and they give their signature, their address, their mobile numbers, and everything. So that's the self-isolation declaration form. I think I can share it later on, and it can be used for other counties as well.
Thank you very much for that. And even as I'm listening to the presentation, I know Mr. Kasim said he had the supplies, and I'm looking at a majority of our population and the statistics we're getting about the people who are actually getting infected with COVID-19. So what happens to that person who is not, they may be asymptomatic, but they are not able to afford everything that has been stipulated? So what do you do with them? Do you admit all of them, and then are there cases that have are there instances that your infectious disease units are full, and what do you do about it?
Well, thank you so much for that question. Yes, initially our infectious disease unit or our COVID isolation unit was full to the capacity, but we are lucky that we formed guidelines, obviously through the Ministry of Health uh, and the World Health Organization's guidance, and we were able to actually form our own self isolation home based care guidelines. However, there are those instances I've earlier alluded to when sometimes not all supplies will be readily available. For example, you might not get everyone having a self contained room. So if in such instances uh, you can support the patient and the household by educating them how to disinfect uh, the washrooms and the bathrooms after use, then that can be a plus point, because every time the patient goes to that bathroom, uses it, thoroughly disinfects, and then goes back to his or her own room. That can help. Not all patients will be able to afford disposable plates and cups and containers. So how can you come about that? Then instead of having disposable plates and utensils, you have a bucket full of 0.5% chlorine water, and after eating they can dip the utensils in that chlorine water, and after an hour or two you can remove it. After soaking the for an hour or two, you can remove the utensils, wash them, and they can be used again by any other person. So these are the things that we try and improvise, so to speak, because not everyone will be able to afford disposable utensils, not everyone will be able to afford a separate self-contained room, and these are the facts on the ground, the reality. So if we cannot, despite improvisation, we cannot uh, come across these things, then unfortunately, but we have to admit such a patient, at least for those period of time where we can think that the patient is going to be infective. So that's the 10 days of being asymptomatic.
Thank you very much for that. And I think there are several people who are asking whether there's risk of going, like, have you seen an upsurge of cases now based that can be traced to the person who has been advised to go for home-based care?
Thank you so much for that question. Luckily, so far we have not yet had any new infection from any of our patients who are on home-based care. That's one thing that is very encouraging, and it is actually showing us that home-based care is possible. Like I said, uh, education is key. You have to educate the patient, make the patient and the household believe that they are the drivers of that particular vehicle. It depends totally upon them. What comes out of the home-based care will be dependent on them, how they will take it, how they will behave. And two, obviously, if you educate and don't follow up, then you're also going to lose this battle. So we have to make sure that follow-up is continuous. Yeah, if you do not, it's actually human nature that if you're not being followed up, you will be tempted to bend the rules here and there. That's why continuous follow-up is actually recommended.
Thank you very much for that. And there's something I'd like to take you back to, where you have a home-based care surveillance team. And I'm wondering, what's the component of that surveillance team? How is it formed? And how do you said that you have around 116 patients who are on home-based care. So how are these patients distributed towards like the cadres that are there, and how does this work?
Right, thank you so much. Now, the components or the people who make up the home-based care surveillance team, it's a straightforward thing. You need to have public health officers there, and you need to have doctors and clinicians. Remember, the public health officers are required because they do the follow-up testing, they do the contact tracing as well. And together with the public health officers, we have also empowered our community health workers or community health volunteers. and they also play a very important role. Um, in other counties, I've heard the Nyumba Kumi is very well established, and that can also be used. You don't specifically need a particular set of cadres to form a surveillance team. Even Nyumba Kumi is a kind of a surveillance, so you need to improvise. That's one thing. Two, the work of the doctor is very simple. The doctor has to follow up, because as you know, there is always a chance of a patient to deteriorate, to change from asymptomatic to becoming mildly or moderately symptomatic, and even for the worst, to even become severely symptomatic. So you need a follow-up, continuous follow-up by a doctor. The clinician uh, has the role of calling the patients. Now remember, we have 116 patients. So what we have done, we have actually zoned the patients so that follow-up can become very easy. So if there are a number of patients from Kisauni, so all those from Kisauni will be handed over to one particular public health officer and his uh, accompanying clinician or doctor. Then if you have, let's say, patients from Changamwe and Jomvu, so from that particular sub-county, all of them will be grouped into one particular group, and the follow-up will be done by a particular public health officer. Remember, even these sub-counties have their own public health offices or sub-county public health officers, so it makes work easier and coordination is also very smooth.
Thank you very much for that. And I think it's really, really eye-opening, even as all the counties are really trying to figure out how to adopt the home-based care. Even as we come to the end of the session, maybe I'd like to ask Mr. Kasim for his thoughts in terms of what he thinks could have been done better to improve his experience while he was undergoing home-based isolation during his time.
All right, I think I'll ask him to answer that question, Mr. Kasim. There's a question, and the question is, what do you think could have been done to make your experience better at the home-based care? Yeah, what things could have been done better to improve your experience of home-based care? Educated well.
Being as a home-based patient, uh, I don't think there is anything better off than what the doctors and the public health officers have been doing. I was very well satisfied after all the follow-ups being done. Till, to be very frank, the follow-ups which they were being doing, the doctors, in fact, the public health officers, every alternate days, they have been calling. I myself was also getting tired. Every day they are going, they are following it up. But it was for the betterment of myself that they've been following it up to see how I am doing at home rather than being in the hospital. But Alhamdulillah, they were satisfied the way I was continuing with the improvement of this COVID. So I don't find myself that there is any thing which I can add up to that, because it is already being done by the doctors and the officers themselves. Yeah.
Wow, that is really, really encouraging to hear about that. So maybe just one or two questions, even as we come to the end of the session. And it's to Dr. Arif, in terms of what do you tell the patient to monitor while they're at home? How do they get to monitor themselves? Do you tell them they have to have a pulse oximeter and give you the numbers? What do you define for them in terms of their monitoring while at home?
Okay, again, another very useful question. And I think I would like to honestly bring this up. Initially, every patient or every case definition criteria that was being used was telling us about fevers and acute respiratory symptoms. But of late, as you know, this is something that is new. New findings are coming up every day. There is new knowledge, and that's why continuous reading is very important. Of late, we have seen a rise in the number of patients who present with diarrheal diseases, with diarrhea, rather than having any cough or difficulty in breathing. So really, it's very hard for us to give all patients a pulse oximeter. But yes, those who are able to buy, actually, there are quite a number who actually had bought pulse oximeters, and it was very encouraging. So those who are able to buy were monitoring their SpO2s, and currently I still have some. While I was presenting, there was a patient who tried calling me, but I just sent them the text that I'll call you back later. So yes, we have a number of patients who have pulse oximeters, or they did buy pulse oximeters, but a big number could not. So what we try and see is if they can have thermometers, and for those who could not even buy thermometers, just them trying to check their temperatures would give us, I mean, just a clinical feel, whether they feel that they are feeling febrile or not. However, the other things that we used to tell the patients are joint pains, sore throats, cough, difficulty in breathing, malaise, loss of sense of taste and smell, which has been very, very common, I would say. And we are even doing another research, the prevalence of anosmia and ageusia in patients who eventually turn positive for COVID-19. And we hope to publish the data as well. And of late, we've also been talking about diarrhea as one of the presenting symptoms. So if anyone who did not have any of these things and is at home for home-based care and suddenly develops any of these, then we usually ask them to call us.
I think it's been a really, really interesting webinar, listening to the Mombasa experience and how they have actually been very innovative and in terms of implementation of the home-based cares. I think I'm really, really impressed as to how you're following up your patients and also your attitude and views towards COVID-19 and your patients. So maybe, Dr. you can give us your parting shot, even as we come to the end of the session.
Well, I am really grateful for having been given this chance to actually serve the people of this country. I remember I was called on one random day. I was actually working as a medical officer in charge of the accident and emergency department. And I was just called by the CEO of the hospital, and he just tells me that, Doc, I need you to move to the COVID unit and you will be in charge of it. Yes, there were mixed emotions, but from day one, I would like to say this, that I had to overcome the fears. And that is one thing that has kept me going to date. I have donned and doffed many times, but the one thing is, if you have your mind set to the positive aspect, then you are bound not to make mistakes. And please treat the patient as a patient. He or she is a human being. They have not made any crime to get COVID-19. Uh, it's not out of choice. No one would want to be in the isolation unit. Uh, the patients need to be given that part of humanity. Usually, I've had calls from up country as well. Unfortunately, I've had friends who are in the transport industry, and they've been telling me that their drivers have been put in isolation centers, and some drivers have fallen sick, and there's no one looking after them. And we have had to make follow-ups. So I would like to tell all healthcare workers, this is teamwork. It's purely team effort. Being a doctor does not mean you're better than being a nurse. Being a nurse does not mean you're better than being a doctor. We are all here in this together. We have to work as a team. We have to encourage each other. I have had times when I was feeling very low, but my colleagues, even from the nurses, even from the clinicians, have lifted me up, you know. So it's about how we work as a team to overcome this thing. Remember, it's an enemy we are fighting, and it's an invisible enemy. We are not seeing the enemy. The last thing I would like to say is a lot of community work needs to be done. We still are seeing quite a number of people who are ignorant. They are telling us that there is nothing like COVID-19, and it's unfortunate. And some of them are actually learned people, but it's unfortunate. The only way to overcome it is continuous education. Talk to the people outside there. And I would say, if it is possible, then patients who have recovered should actually come out and actually talk of their experiences so that people can know that this thing is real, and stigma will actually reduce because the real perspective of the disease will come up. So that's all I have to say.
Thank you very, very much, Daktari. I love your attitude. I love the way you're looking at patients as people and not labeling them as COVID-19, and your dedication to the service of humanity. And I think that is really, really commendable. We've come to the end of this session. Kindly tune in tomorrow at 2 to 3:30, where we'll be talking about supporting home-based care with Jitenge system. So introduction and a practical demonstration of how it works. I believe that this session has been really eye-opening, and one of those sessions where hopefully a lot of us will sit down and reflect on how we are treating our patients in the various counties with COVID, suspected COVID. And I'm hoping through this presentation, we'll be able to revolutionize our treatment and our management of patients with COVID-19. And I think what I've gotten out from this is COVID-19 is not a crime. And I think that's a slogan that we need to take out there as healthcare workers, that COVID-19, yes, indeed is real, but it is not a crime. Thank you very much, Daktari and Mr. Kasim, for taking your time to give us your experience. And we really, really, really are very, very grateful. Again, for anyone who has queries of CPD, kindly email us at knetcpd@gmail.com, and we shall be able to address your queries. Thank you very much and have a lovely afternoon.
Thank you.